Hello, good afternoon. It's a great pleasure to be here with you, and I hope that I might have a timer maybe here, just to know that I'm not talking 5 hours, because that may happen. And I was invited in this sponsored session with great pleasure to discuss some specific issues within the interdental space. My name is Filippo Graziani. I do not believe to any conflict of interest, of course. The vast majority of my research is supported by companies, and these are some of the companies that supported me. In case you want to give me more money, I'll be very happy to receive it and to run even more trials. But this is really the people that I'm working with. So what I would like to focus now with you is to make a little preamble and understand the anatomy of the interdental area, to understand why it's so important to control plaque interdentally, and especially how to achieve it, and then ultimately to understand the systemic effects and the effect that goes beyond the oral cavity in terms of oral hygiene and plaque control. So all the cases that you are seeing here that are stage 3 and stage 4 periodontitis would actually benefit dramatically from periodontal treatment. In fact, these are all the cases that are stabilized after periodontal treatment per se, which is based on 5 important steps. In fact, we have a screening diagnosis at the end, and then at the beginning, and then we have the rest of the sequential phase of our treatment. So the first point and the first important question is to understand whether we really need plaque control or not. In fact, when we have a patient like this one, her name is Maria Elisa, and you see Maria Elisa before and after step 1, in which we just not remove calculus and accumulation, but we work on her capability to actually maintain this plaque control. Plaque control is fundamental, and the classical studies are in fact telling us that as much as you might be good with your hands and have all the technical dexterity you want, if you are cleaning somebody that does not have plaque control whatsoever, you'll see benefits that it will last perhaps around 2 weeks or so, but within a month, whatever you do will just go back exactly where it started. And when you understand that step 1, so plaque control is fundamental, you'll see that in fact the absence of plaque control would basically render step 2 completely useless. So there is no way that any periodontal treatment may work without plaque control. In fact, without plaque control, there is no treatment of periodontitis. So how do we empower plaque control? Well, I actually like always to say, not to have a philosophical approach about it. You know, bringing somebody to make a behavioral change is like teaching or bringing somebody to make, let's say, a tennis match. First of all, you need to want it and be willing to play tennis, and secondly, you need to know how to play tennis. So motivation is really to provide the patients on understanding why, with some internal intrinsic motivation, and that's one step, let's say one phase of your professionality, and then providing instructions, because instructions will not motivate anyone. Information is not motivation. Knowledge doesn't do anything. So that's why a dental hygienist should actually be proficient in both sides, which are different steps, different stages of step 1. Now, when it comes, in fact, with plaque analysis, it's very clear that plaque would tend mainly to locate itself within the interdental area. That's why I believe that it's fundamental to have a plaque assessment. Plaque assessment per se, so a full mouth plaque score, is not just giving us a number. But what I think is fundamental of a full mouth plaque score that, as you know, is aiming at giving both an overall amount of percentage, but also the distribution. So if you see that, for example, in these 2 cases, we have 2 different types of plaque control, and therefore, in the cases in the upper, you just see plaque that is located interproximally in the molars. That would imply that my tailored oral hygiene instruction would focus exactly on making sure that this area is going to be covered. and if you want to see it in another way, if the patient just don't do anything from 5 to 5, my personal instructions would be from 5 to 5, please keep on not doing anything. So the point is to be effective, not to provide an elegance in oral hygiene instruction. So without assessment of plaque distribution, I believe that it's not possible to provide adequate skills. So it has to be a sort of a diagnostic process of where the plaque is, and then followed a tailored instruction. So where do the plaque goes? I mean, when we check it, it is very clear that everybody is dirty in its own specific way. But mostly, dental plaque is interproximally and is located distally. So when we go and check the areas that have plaques or not, the majority of the patients have no plaque in the frontal and the buccal area. There is some inconsistent amount of plaque interdentally, and also the actually pretty consistent plaque in the interproximal molars. I really would like to have a timer, otherwise it's going to be very complex. But interdental plaque is in fact very different from that. Thank you very much. Is very much different from the rest of the other part of the oral cavity, because it's more acidogenous. Therefore, there is a likelihood to have a complete different dysbiosis compared to other part of the mouth. And in fact, it would tend to develop more disease. It is not by chance that clinically we have the majority of attachment loss is interdentally, as much as in fact even the caries are mainly located interdentally. So plaque accumulates interdentally, where it enhances the likelihood of a disease. So what is the problem with the interdental area? It's the anatomy that is erratic and random and changes. And actually within each papilla can change significantly. And usually the interdental area is divided in 4 pyramids. And all pyramids actually will end to the contact point. We tend to assume most of the time, and I think that's a normal human bias, that the papilla is the cervical pyramid, so it's actually the perception of the buccal image of the papilla per se, which is in fact the papilla and the space between the tip of the papilla and the contact point, which is the area that is usually the target of our interdental cleaning. Now, there is a classification, and I'm sure you're familiar with the northern internal classification, that is dividing the papilla according to 3 anatomical landmarks, which are the contact point, the point in which the interproximal CEJ would turn actually towards buccally, and of course the apex of the facial CEJ. So according whether the papilla goes in between the spaces, you classify them in normal, in class 1, class 2, if there is an exposure, so if there is interdental attachment loss, and class 3, when actually this loss is even superior, or at least more apical than the CEJ at the facial aspects. Classically, the classification also requires even amount of millimeters that is dividing from the contact point to the tip of the papilla to really understand how the papilla looks like. However, this classification is once again focusing on the buccal component of the papilla per se. And the thing is that the interdental area has a triangular shape that goes to the contact point, and what happens is that clinically, well, and visually, let's put it this way, whenever we look at the palatal papilla as well, our mind would translate the papilla as a sort of pyramidal shape, but it's very likely that maybe not even between a lower incisor, lower lateral incisor and lower central incisors, you might have some sort of pyramidal shape. In fact, the papilla has this kind of a saddle structures with a long part in the middle that is called the caul. And a caul actually is a significant portion of the papilla. It can actually vary from few millimeters, maybe 1, up to 10 to 12 in the molar area. I would say that the vast majority of the mistakes that are done surgically are due to the non-comprehension of the interdental anatomical area that, as you can see, is a very lengthy tissue that in fact is going to be a mucosa that has an interface with dysbiotic plaque for a long time. And you can see here, for example, we have nearly 10 millimeters of a caul in this area. So why it is so important to control plaque? Well, when we check the essence of how periodontitis is developing itself, we know that we control plaque mainly mechanically and chemically. Mechanical through manual and power toothbrush, interdentally with flossing and interdental brushing. There is also wood picks also irrigators, but I would now just focus on the two, and then some chemicals. Being the mechanical the main plaque control, and the chemical something that may provide some adjunctives. Now, the main issues that we have as clinicians, first of all, people would brush their teeth very fast. We know that theoretically it's about 50 seconds, but in reality it's around 30 seconds. Now, please all look at me. If I look at you, all of you will remember when you start to brush your teeth, but nobody would remember when you finish. It's magically the toothbrush is over there, and you've been going through where you're going to park, how you're going to go to school, and so forth. The reason being is that we tend to take 70,000 decisions every day. Therefore, thank God our mind has an heuristic process so that we tend to develop habits so we don't have to waste energy. And in fact, toothbrushing is something that goes automatically, like when you drive back home with the same street every day from work. That implies that the majority of the people would actually clean for the first and only 10 seconds of being conscious, what? The upper buccal central incisors, which are the surfaces that are already clean per se. That's why I think it's important, and we'll discuss this later, EuroPerio to me, first of all, is to change the order of brushing. First of all, you start interdentally in the difficult areas, because it's where you're going to put the highest amount of concentration. And that, let's face it, cleaning interdental is difficult, and I'm sorry to say, but I've been collecting plaque, full mouth plaque score for trials for all my life to dentists and dental hygienists, and we are as dirty as the one outside. So it is, if it's difficult for us, let alone for the people that are patients or population, and we tend to be very fast. And we had this discussion with Professor Dagmar Zolot in previous debate at lunchtime. In fact, dentistry is relying on, and let me use the phrase, business model that is based on creating profit on some technical and mechanical action with our hands. So one of the main difficulties that we have in EuroPerio is to provide sustainability from an economical standpoint on step one, which is simply working on motivation and behavioral changes. So we tend to be very fast. There are too many chemical agents, and I don't want to make exams, but every time that I have my students and I ask them and I give them 4 brands of toothpaste, they never know the active principle. And origin instructions are often made on models. And if you remember how long it took us to understand at the university that looking at X-rays is actually looking at somebody that is looking towards us, it's actually very complex to teach somebody specularly in a mirror fashion how this works. So understanding the plaque control, I think one of the dogma that we have is based on the pillars of origin, which is a paper from Axelsson and Linde in 1981. Long studies published by Axelsson. But this one I think is fundamental because we have 2 large groups that were actually divided in people that would attend just once a year some, let's say, dental cleaning with just random motivation, and versus a group that actually would come every 3 to 4 months and would be professionally motivated and re-clean all the times, and then followed up to 6 years. So if you control the plaque level buccal and lingually, interestingly enough, in the control group, after 6 years, there is a significant diminishment of the plaque. Interdentally, of course, the plaque was everywhere and remains exactly where it was. So that means that without any actions, there is no way the interdental plaque can vary. What I think is interesting, though, that if you look the amount of bleeding, you would see that interproximally, of course, the inflammation in 6 years would raise, which is normal because the plaque would remain. But even buccally lingually, despite the plaque was lower, inflammation goes higher. Because, of course, if you have a distal papilla that is inflamed and a mesial papilla that is inflamed, it doesn't matter whether you have plaque control in the buccal surface. That implies that the areas that is exposed to inflammation, which is the interdentally, has really the capability to modulate all the inflammation in the oral cavity. And if you go to the test group and you check it, you'll see that plaque interdentally would diminish, and therefore even inflammation, and let alone caries that will not develop. I think this is fundamental. In fact, in a consensus meeting of nearly 10 years ago, one of the key points that was highlighted in secondary prevention of periodontitis, i.e. treatment of gingivitis, it is really to make sure that interdental cleaning was something that should be professionally taught and motivated. So the maintenance of the interdental area with limited or no plaque is really, to me, the keystone of oral health. There is no way you can preserve oral health, especially in somebody so prone to have further disease progression, such as periodontitis patients, without interdental plaque control. So how do we manage interdental plaque control? Well, there are, of course, mechanically some specific issues, and clearly floss has been quoted as one of the pillar of interdental cleaning. Now, cleaning with the floss interdentally equals cleaning two surfaces. So it's two different moments, two different separate actions. And in fact, we tend to teach floss in the interdental central papilla. We hardly teach floss in distal of an upper six, where actually it would be needed, but that's a different story. So flossing, and I'm not going to come into EuroPerio to explain how floss works, but the thing is that flossing is an extremely complex and difficult technique. This is Silvia, my co-worker, that that voluntarily agreed not to brush her teeth for 2 weeks. That was actually an event. I was invited in 2010, and the title of the event was to the evidence base that was behind the usage of floss. So I took a picture to Silvia. Now, bear in mind, this is me passing the floss to Silvia in 2010. I've already been specialist since 2005. I have, I think, decent hand. I know the anatomy. This is an accessible area. And this is the end of me cleaning. You see, there is really not much change in plaque. So the issue is that if I, as a professional, am not capable to do it, would Miss Maria from Marina di Pisa capable of doing it after just one session of step one? So I think one of the landmark studies, as many, is coming from the ACTA of Amsterdam, from the group of Fridus van der Weyden and Dagmar Solot. In this study, basically, they compared all the studies that did manual toothbrushing versus manual floss. If floss worked, you would agree that these people would have less plaque than the others. Actually, on 11 studies, 8 of those reported no differences. And in fact, you would say, well, but you see, one story is to give a medication. Another thing is to provide a dental floss. If you just give a dental floss, nobody would be capable of using those. But 3 of these 8 studies are done on dental hygienists and dentists. So not even us are capable to show that there is an adjunctive effect on plaque. So when I said this in 2010 at the Italian Society of Perio, few hygienists waited for me outside, and I walked out, and back then I had some ambitious plan, and they were very good looking, so I thought they were waiting for me for other reason, but in fact they wanted to punch me. And I remember they said, you should not say these things. And I said, but this is the evidence. And the answer was, it might be the evidence, but there is young people in the audience. So something I never really quite understood. But now it's kind of accepted that for plaque control floss, it is really not efficient. However, in the years, I also was invited to restorative consensus. And they used to say, well, for you as periodontists, you like these things. But how do you clean the contact point? How do you look after caries? Well, there is systematic reviews on this topic by Filippo Graziani that always have, I have to say, it's a researcher I like it because they always have a very heretical approach. And in fact, he showed that only in kids you could see that flossing would reduce 40% of the incidence of interdental caries if the dentist would pass the floss 5 times per week to the kid. And in fact, I remember a consensus conference that we did with the ORCA, the Association of Cariology, and they kept telling me that passing floss would actually, in fact, open the contact point. So this is really one of the bases that support the statement of the clinical guidelines of the EFP, for which flossing is really not the instrument of first choice for interdental cleaning. And there is, of course, lots of support of interdental brush, and as you can see, interdental brush is very effective. And the evidence is drawn once again by a paper from Dagmar Schlott and Fridus van der Weyden. Clearly, interdental brushes rank the highest, both conical and cylindrical. There is really not much difference when you go and check the direct comparisons among the two. But floss, power toothbrush, irrigators, wood sticks, they do not prove to be beneficial over just classical manual toothbrushing. And most importantly, interdental brushes are easier to use. I mean, there's no way. Of course, I use floss on me, and there is no surprise that some of you would use floss. But a different story is to have somebody on a chair for once or twice and passing something that would be effective and rapid. So this is the base really of the guidelines, this paper that we just quoted, for which toothbrush should be always supplemented by the use of interdental cleaning. Now, the point of interdental cleaning is very clear, and I do it always the same. First of all, I show the patients how to do it. This is, for me, just to understand the caliper, the dimension that I cannot see visually. And this is very important because in Anna Maria's mind, the point is that this can be done. That's what her mind is reading. Then once I finish, I simply hold the mirror, and then Anna Maria is doing exactly the same. So that I think this is very important because now her mind is doing, I can do it. This is called empowering. Empowering is fundamental. When you enter a room and you get out and you know how to do things that you wasn't be able to do it at the end, is tremendous. So I think, to me, and then of course you touch with the blood everywhere, so Arianna, my nurse, is very happy. But I think what is very important is that you need to send the patients away that have covered all the interdental space. And done. That's it. I don't do any more. 1 minute of interdental cleaning, 1 minute of oral hygiene instruction. It's enough. People is happier without instructions of oral hygiene. It has to be fast and effective. There is no philosophy here. When it comes back, we'll check if it works. If it works, then we may add toothbrushing. But that's the first thing that I work on. So they have to be professionally taught. And as you can see, we dress them like this every time that we do oral hygiene instructions. But the point is that I usually count, and I count very slow to 10, reason being that the patient will make any effort to shorten it by themselves. So there is no reason just to be very fast. So, so the patients, and I always have it to do it twice. The reason is very easy. It's just to counteract a typical shyness of anyone. If you ask somebody, please show me how you brush your teeth, it's not an easy moment. So repetition remove actually terror. Repetitions remove embarrassment. So allows me really to understand how this is done. Now, the main point of interdental brushes, however, that they need to be large enough to sustain the concavities and the variation of anatomical areas that we have when we have lost attachment because of the hourglass of the root surface, and also because of the caul. How large? Well, as long as the enema, as long as the central part is not touching the teeth and the brushing can be done effectively, I would say the larger the better, with no discussion about it. Now, the thing is that once we select the size, you might end up, of course, with different sizes. But there is no way that I think could be sustainable if you give more than 2 sizes. First of all, it's not sustainable psychologically. It might not be sustainable economically. So 2 sizes is really more than enough to cover all the interdental area. They actually leave us the dilemma what to do in the papilla that you cannot do anything. You just don't do anything, full stop. I mean, this person haven't cleaned its interdental area for all life. If he now cleans the 80%, is already a massive success. With the time, however, what I've noticed that the people that start to have low plaque control would ask you then how to solve some specific problem. And then you can suggest maybe some high quality flossing or something specific for some specific areas. And I like the fact I found these studies done on dental students in Iran, assessing whether using interdental first and then brushing is more efficacious than doing brushes and interdental floss. So the timing on interdental, in this case flossing. And it is, and that's very assuring because in all my life, I always give interdental first and then brushing. To me, as it is the most important thing, I always say to my patients, do interdental twice a day, then you can even brush only once. And nobody would do it, of course. It's psychologically something that no patients would endure it. But I think what is important is to stress the fact that interdental is the most important, and you start with that because it's where you're going to work the most. So max 2 size, ideally twice a day, large enough to capture root, concavities, and caul, and I would use it before toothbrushing. So the problem with interdental brushes is the trauma. Now, the vast majority of the trauma are, in fact, the papilla tips. And the reason is anatomical because of the Wilson curve. And clearly, if somebody is using interdental brush horizontally, would actually pass the buccal, but would hit the tip of the papilla on the lingual side. So in that case, we just need to bring the hands up and show the patients to go a little bit more coronally, and that would solve it. However, in the acute phase, just remove everything. You can give maybe some corexin and some hyaluronic acid, just wait a few days for reepithelialization, and then move, perhaps even to a smaller caliper. But most of the time, it's not a matter of dimension, it's a matter of incorrect techniques. However, there are some mistakes. This is Veronica. Veronica, to me, had a diagnosis of stage 1, a lovely young lady, but it was a mistake. I did a mistake because I didn't listen to the patient carefully. We actually reported histories of discomfort, pain, and with the time, I tend to incline that there was a necrotizing periodontitis that had healed more than a stage 1 periodontitis. And I actually found out retrospectively, because we went through interdental brushes, and you see the papilla actually change with some concavities. That didn't look quite right to me. So I really wonder whether, in a way, I was invading a sort of a biological space. So we reverted to flossing, and you see the change of the papilla by changing to brushes to flosses. So when trauma is foreseen or can actually be acknowledged, I think flossing, if it is of high quality, should be used. If it is just archery on the papilla, then there is no need. So an alternative, of course, is the use of interdental peaks, which are actually rather interesting because you see, even in small areas can be quite effective. So we wanted to run some trials to understand whether they were effective or not. And we ran 2 trials in which we assess our patients, which were actually randomized to 4 groups, which were negative control group, which is just toothbrushing and floss, toothbrushing and interdental brushes, and toothbrushing and peaks. And then we assessed after 1 week. Therefore, we randomized people. We gave instructions without cleaning them. This is what I call the unclean phase. To me, it was important to see the performance of the instrument on the mature plaque. Then we cleaned our patients, and we followed them for a month. And this is what I call a clean phase. In clinical trial, this is what is called plaque accumulation, reaccumulation trial. So we go from 0 to then let the plaque with different instruments and see how the plaque would grow or not. So it's 2 different models in the same trial. But one other difficulty that I found in literature, that all the studies were done on various types of papilla with no explanation. So we divided the trials in 2 arms, into trials. One was done on people with interdental papilla that was intact, young people with no periodontal attachment loss, and another one was done on periodontitis patients, because this is really what you have clinically. You have people that are healthy and people with periodontitis. So the trials were specifically done on 2 different populations. The first trial actually what indicated, of course, we are people in their 20s with interdental papilla, and there is a significant reduction of plaque in all groups, but the interdental plaque was significantly lower in people that use interdental brush and peaks compared to toothbrushing alone. When it comes to assess the interdental bleeding, what I think was interesting is that the peaks versus flossing showed a greater reduction. That's rather interesting because, to me, of course, maybe I'm pushing it a little bit, but the fact that brushing and peaks would remove plaque to nearly the same extent, but the peaks would actually show on an intact papilla more bleeding control. It's something that goes beyond plaque. To me, it might be what my grandfather, I come from a family of dentists, used to say about brushing. It's a sort of a massage effect that perhaps was done on the papilla that would explain the data. Of course, it's just a pure speculation. When it comes to the other trial made on people with periodontitis, and no worries, I'm not going to read the table, but basically the interdental plaque was reduced everywhere, but the subjects that were treated with interdental brushes or rubber interdental peaks versus aluminum versus flossing showed lower results. And what is interesting that in the unclean phase, only interdental brushes and rubber peaks showed changes, and in the clean phase, the interdental brushing peaks also received the highest amount of bleeding reduction. So on the basis of these two trials, to me, the rubber picks and the interdental brush are really the instruments that can be used of choice, clearly towards floss, both in people that are with intact papilla and people with periodontitis. So, to me, going back to another milestone, without interdental plaque, so if you don't want to have interdental plaque, you need to go for interdental brushing or picks. So let's now move to the last component. So whether oral hygiene improvements determines systemic effects. So we know, and this is a consensus that we ran with between the European Federation of Periodontology and the World Heart Federation, that one of the critical points in reducing acute cardiovascular disease is the fact that the patients may actually clean more. This is not made on trial, for ethical and I would say even pragmatic reason cannot be seen on trial, but it's done in very cohort study, in cross-sectional studies. And it is clear that the people that actually brush more, that have higher tendency for oral hygiene control, would actually show lower risk of acute cardiovascular disease once, of course, data are adjusted for confounding factors. This is true both on a Korean population and a Scottish population for the studies that were included in that cohorts. Now, I was also given this study recently. I was attending this meeting in Japan, and a paper that has not been out yet, but is a cross-sectional studies on patients affected by diabetes. And it was assessed many factors, among which the frequency of interdental brushes, dividing patients, whether they would do it nearly regularly or erratically, interdental plaque control. What was interesting that they followed not just the level of glycated hemoglobin, but also the continuous 24 hours glycemia with sensors, and they measures the time to range. Time to range is the time that is spent by a patient with a range that is below a threshold, a specific threshold of glycemia. So the amount of time during the day that the patient is staying on a low risk level of glycemia. And when stratified according to the dental clinic habits, the one that would actually clean interdentally would show more frequent time to range and lower level of glycated hemoglobin. I believe that this study is a preliminary study, hasn't been out yet, but I think it's rather interesting. So in this regard, I will show you one trial of our group in which we assess 140 patients with generalized gingivitis. The point of this study was to see whether the treatment of gingivitis would determine also some systemical changes. So that's why it was such a large sample, because on our previous pilot, you need to see a significant amount of people to see small fluctuation of systemic inflammation. In people with periodontitis, you'd have higher level of inflammation, but gingivitis is a different story. So what we did was we randomized our patients to be treated, as in cleaned, but in the control group, people were just receive a normal, let's say, professional cleaning, and then would be seen after a month. Of course, we would collect blood samples before and after 1 month, and also make some quality of life assessment. But in the test group, people was seen every week, and every week was reinforced and remotivated. Now, what I think is interesting, this is Stefano, one of the case, and you see Stefano has a generalized gingivitis, this is Stefano before, and this is Stefano after the treatment. Now, which are the results? As you can imagine, reduction of plaque and bleeding were noticed in the test group, very little in the control group. But what was important is that we also measure the amount, all the patients that went from having a diagnosis of generalized gingivitis to none, which is what we call gingivitis resolution. And what is interesting is that the people that were seen every week for a month would be solved, would be cured, because gingivitis in fact can be cured, would be cured 9 times out of 10. Whereas if you go and see the ones that actually had just been cleaned in a month, only just once out of 20 would actually be cured, i.e. cleaning someone doesn't do anything to gingivitis. Gingivitis is a proper disease, let's face it, and requires a protocol that is not sustainable with just 1 session, and the data is pretty clear. Now, but we also check the amount of systemic inflammation, and you see that there is a significant reduction of high-sensitive C-reactive protein and also some fluctuation of interleukin-6. And when we analyzed the quality of life, the ones that were just cleaned in a month has showed no difference. But the ones that were cleaned and every week remotivated showed a change of the parameters of oral health-related quality of life that were, to an extent, I'll try to make it, to an extent that is considered significant for the true life of the patients. Basically, I'm saying this is not just a statistical trick in which you say changes. There are some threshold of changes in psychometric testing that are considered to be relevant to the life of the patients. And that was actually the range of reduction. I.e., if you treat gingivitis, the patients would feel better overall, and you would treat gingivitis efficiently. When we actually made this regression model, it was clear that to witness a reduction of systemic inflammation, you need to go below 8% of bleeding. Now, if you think that the threshold of diagnosis is 10%, I think it's quite nice. It really makes you feel that once you cure gingivitis, in fact, it's very likely that you have a reduction of systemic inflammation as well, and improvement of quality of life. So, to sum up, and I still have 5 minutes, but I think we can close it now, that without plaque control, there cannot be the treatment of periodontitis. Without assessment of plaque distribution, it is not possible to provide adequate skills. Plaque accumulates mainly interdentally, where it enhances the likelihood of disease, and I think this is very important. In fact, it's not my sentence, it is quoted directly from Axelsson and Linde. The maintenance of the interdental area with limited or no plaque allows the conservation of oral dental health throughout time. Brushes, I would give 2 sizes twice a day, large enough to capture concavity and caul, and very importantly, as the first thing, as the most important thing, because it is the most important thing in dental plaque control. And when trauma is foreseen, I would consider flossing or PICS, which is really the instrument that I want to use when I don't want to have plaque interdentally. And remember that interdental plaque control and overall improvement of hygiene actually determines beneficial changes that goes beyond the oral cavity. So with that, I thank you very much for your attention. It's been a pleasure to be here with you. And